Great. We're going to switch gears back to women, and the focus of this presentation is on the metabolic and cardiovascular risk in polycystic ovarian syndrome. I have no disclosures. So this is a practical talk about when women come into your office, I think, who are complaining of irregular periods and signs and symptoms of hyperandrogenism. I like to think about the differential diagnosis of hyperandrogenic anovulation with the following list of disorders. The most common is going to be PCOS. But as we take the history and do the physical exam and do the laboratory tests, we want to never miss an ovarian or adrenal tumor, extremely rare. We want to make sure in the current global epidemic of people taking things that no one's taking an androgen or some exposure to androgens or other medications that might cause some of their signs and symptoms. I'm going to mention a disorder that I think is very prevalent that isn't PCOS, that's obesity-induced hyperandrogenic anovulation. And before we make a diagnosis of PCOS, we want to exclude non-classical CAH, occasional Cushing syndrome, a prolactinoma, all of which can present with hirsutism and irregular periods. So let's start with a case. 19-year-old woman presented with hirsutism, acne, and irregular menses since her menarche at age 11. Women with PCOS will tell you their periods never were regular. Most normal women have about 18 months after menarche where the periods are irregular and then they become regular. She had hirsutism on her face, hirsutism since age 9 on her face, chin, and around her breasts and below her umbilicus. So 20% of women, and probably more in certain populations, have hair below the umbilicus. Above the umbilicus, upper chest and upper back is where we're worried. There were no signs of virilization. Her periods are always irregular. She'd had 3 in the last year, 1 in response to progestin withdrawal. She's also complaining of gradual weight gain, difficulty losing weight despite diet and lifestyle, and importantly on her family history, she has type 2 diabetes, obesity, and hyperlipidemia. Sound familiar? It's very common in our practice. She had an anabolic appearance. Her BMI was 29. She had terminal hair on her upper lip. Lots of women have that. Chin, neck. She had no signs, importantly, of temporal recession, grade 2 acne, and importantly, no clitoromegaly, greater than 2.5 by 1.5 centimeters. Her timed labs, and I recommend taking timed labs. We made her have a period if she's not having any with progestin, showed a higher LH to FSH, 15 to 5, a high testosterone, but not in the male range, a slightly high DHEAS, the sulfate is what you should check, a borderline high A1C, and importantly, a normal prolactin and a normal 17-hydroxyprogesterone. There was no reason to work her up for Cushing's based on her signs and symptoms. So there's been a recent nice article that I'll be referring to that has some great data in adolescence and into young adulthood of PCOS. But here is the evolution in the diagnostic criteria that we now live with. First, the NIH criteria, then the Rotterdam criteria, and the Androgen Society criteria. If you use the NIH criteria for PCOS, it predicts metabolic and cardiovascular risk, which is our focus today. If you use the Rotterdam criteria, it predicts infertility. And the mixture predicts both. Okay, oligoamenorrhea, 8 or less menses a year, hyperandrogenism, it can be clinical or biochemical or both. And then polycystic ovaries on ultrasounds. Notice that the NIH criteria does not include that as an absolute criteria. The Rotterdam did, but it allowed you to just have cysts on your ovaries and no signs of hyperandrogenism. That didn't make too much sense. And so the Androgen Society guidelines had to have the androgens plus one or the other. Okay, so she had all the signs, symptoms, and she also, I didn't do an ultrasound, and I don't do ultrasounds in my practice, but we'll talk about that. So here's the famous that we heard about this morning, the Ferrum and Galloway score that you can use in your practice if you're treating patients with any kind of hirsutism as a response to therapy. You need to understand the baseline ethnicity of normal ranges, and usually 4 to 6 on the criteria is abnormal depending on the ethnicity. We know the classic features of histologic and anatomic of the polycystic ovary, their string of pearls, its multiple subcapsular cysts. And if you have a great ultrasonographer, that's great, you can see those. If you don't, anovulation of any cause will cause cysts on the ovaries. So you have to be careful of calling everyone as having PCOS. I looked at the literature and I could find several small reports of PCOS in India and their clinical presentation. The incidence is similar to the global epidemic of up to 10%. The clinical prevalence and signs and symptoms are similar with the irregular menses, oligoamenorrhea, infertility, hirsutism, and eventual obesity as signs and symptoms, with an increased body mass index with time. Now, we still don't understand the underlying pathogenesis of PCOS. There appears to be a genetic predisposition on the left of excess androgen secretion. By the time we see the patient, there's an abnormality in the GnRH pulse generator that causes a higher LH to FSH in pulse frequency, and we know by models where we do ablation and replacement that a high pulse frequency increases LH and suppresses FSH, and we need a slow pulse frequency to induce good follicles to ovulate. So this tonic fast frequency produces high LH, it produces an ovulation, it activates androgens in the theca cells, and they're decreased SHBG, local androgenic effects causing the hirsutism and the acne. There's tonic estrogen, so they have unopposed estrogen, and that causes some of the side effects we'll talk about, the endometrial cancer, etc. Now, what is the sort of cart, what is the egg, and what is the chicken, and what is the initial trigger? It's hard to know. There's insulin resistance in women with PCOS, whether you're thin or whether you're obese. And it's more than you would expect for the degree of obesity. The genetics are still complex, and GWAS, the multiple genetic studies, they've given us a lot of genes, but no sort of markers or biologic markers. But they point to the ovary, they point to abnormal FSH, and rather than the metabolic issues. So not every obese woman has PCOS, but PCOS can come in a thin variety, or with our global epidemic of obesity, more often now an obese variety. So for case 1, what are we going to do for her? She has PCOS. Our goal is to regularize her menses. We would give an oral contraceptive with a constant, less androgenic progestin. We tend to use norethindrone rather than birth control pills with levonorgestrel or norgestrel. You can also use norgestimate or the spironolactone derivatives. Some of the older birth control pills have less risk of clotting, and so in an obese population, we would tend to use them. Why are you doing it? To shed the lining of the uterus so they don't get endometrial cancer, and to increase SHBG, antagonizing the androgen effects. I see a lot more women getting IUDs, at least in the US, and the levonorgestrel IUDs, although they're great for contraception, they're androgenic, and in my experience, they often worsen the PCOS phenotype, so be careful of those. How do we treat the hirsutism? Spironolactone is cheap. You don't have to go above 100 milligrams a day. You can give it once a day. Often 50 will control it, plus electrolysis. Diet and lifestyle are part of every prescription for PCOS. And I think most of us would also consider an insulin sensitizer. Most of our data is with metformin. It has a role in preventing or halting, slowing the progressive weight gain. It always improves androgens, but only in combination with the birth control pill, plus or minus spironolactone. It improves insulin sensitivity. And those 3 approaches are our main approach in women who don't want fertility in PCOS. There have been studies looking at other drugs, and they haven't come to fruition yet. So now let's go to the next case. This is a 33-year-old woman with PCOS. She has irregular menses. She's had 2 children with induction of ovulation. Her BMI is now up to 32. She has stable hirsutism. She currently is being treated with metformin and an oral contraceptive, and she wants to know what are the long-term complications of PCOS, metabolic and cardiovascular complications. So as we think as providers of treating PCOS across the lifespan, we're not just sending them to the reproductive endocrinologist for fertility. It's our job to treat them as children, as adolescents, in the 20s, the 30s, in the 40s, the 50s, and the 60s. And how do we do that? Again, in the younger women, we want to prevent endometrial cancer. Let's look at the data on metabolic and cardiovascular risk, and then we'll just mention some of the other risks that may feed into metabolic and cardiovascular risk, the OSA, the NASH, and the depressed mood. PCOS women get endometrial cancer early. That's an important take-home. If they can't take the birth control pill, you have to give them intermittent progestin to shed the lining of the uterus because they have unopposed estrogen. Here's a retrospective analysis of women with PCOS in endometrial cancer versus controls. And if you look at the white bars here, those are the cases of endometrial cancer, and they're shifted to the left. Most other women with endometrial cancer get it closer to the perimenopause, or at least after 40. Women with PCOS are getting endometrial cancer diagnosed early if they haven't had their uterus lining shed. That's totally preventable. What about the risk of diabetes? And this is the recent big review article on PCOS by Teed and colleagues. It's in Clinical Endocrinology that I'll point you to. And you don't need to look at the top part of the ballot, but they looked at why are women with PCOS getting into trouble metabolically. It's partly their family history and their genetics. They have an increased risk of gestational diabetes, impaired glucose tolerance, and eventual type 2 diabetes. 3 to 5-fold increase in type 2 diabetes, and of course it's higher if they have the concomitant obesity, but not every obese woman gets type 2 diabetes. Our job is to assess their glycemic status at diagnosis and then every 1 to 3 years based on this guideline. In a family that has obesity and a family history of type 2 diabetes, the most sensitive test is an oral glucose tolerance. However, many centers and the cost and the convenience is complicated. Fasting glucose is okay, and A1C may actually be better because many women get to diabetes not with impaired fasting, but impaired postprandial rise. In pre-pregnancy, we want to do an oral glucose tolerance at less than 20 weeks, and then again at 24 to 28 weeks, and treat aggressively. Again, in the long-term risk in PCOS, in a large cohort of studies, increased infertility, again, the reproductive gynecologist were treating these patients, but a dramatic increased risk if without intervention. No difference in all-cause mortality, but no difference in breast cancer, the increased risk of endometrial cancer, the coronary disease we'll come back to, diabetes risk, hypertension risk, and hyperlipidemia, the metabolic risks. Here's the data on the metabolic syndrome risk in PCOS, whether you use any of the criteria, glucose, blood pressure, triglycerides, HDL, and then as associated with BMI, you see that PCOS in the black bars is statistically increased compared to controls or NHANES cohorts. Now, what do we do about CVD risk and weight management? We want to monitor their weight every 6 to 12 months. We want to assess their individual cardiovascular risk factors. We want to assess their lipids at diagnosis and then per CVD guidelines. And we got to check their blood pressure at least annually. Women with PCOS have increased cardiovascular risk, probably associated with their increased metabolic syndrome risk. But it's been argued whether or not they actually have increased CVD risk. And partly that's because we didn't have a cohort of women followed across the menopause when cardiovascular disease increases. And I don't think we're still there at knowing what their absolute risk is. So it's been argued that the rest of the population of cardiovascular risk catches up to the PCOS women who had the risk markers at menopause when they lose estrogen. Here's the meta-analysis of stroke and non-fatal heart disease, and the data was significant in the upper panel for stroke, i.e. hypercoagulability because of their hypertension, and not significant, it touched 1, but you notice it's on the right side of the bar, the triangle, suggesting they may have an increased risk. And stay tuned for future data. What about other risk? Obstructive sleep apnea, increased risk in patients with PCOS. You know, sleep apnea has been shown to be an independent risk factor for heart attack and stroke in men. But what about women? Women haven't been studied, and PCOS women have more OSA. So if you can use the Epworth sleep scale to look for signs and symptoms of obstructive sleep apnea. Now I'm from Denver, Colorado, and it's at a mile higher, very high. It's increased with altitude. Women have sleep apnea, and some of their metabolic consequences, their lifestyle, their energy, their ability to comply with a diet is improved if we treat them with CPAP. But is it only their BMI? The other issues that's become a huge issue, and it was interesting at the morning reception, inception that we talked about NASH. NASH is a huge issue in PCOS, and we're going to be hearing about it. And lastly, in the largest meta-analysis, mood has been associated, quality of life. And is it a side effect of the obesity and changes in self-image, or is it part of the overall process of PCOS? And we need further data. Depression is higher. Here's some of the data about obstructive sleep apnea in a study in fertility and sterility. As you go across the bar, non-obese PCOS don't seem to have very much obstructive sleep apnea. It seems to be more associated with the obesity, but higher than obese matched controls. And the NAFLD data, here's a recent meta-analysis about NAFLD. NAFLD is dramatically increased in PCOS women and should be screened for. Here's another more recent one showing a relative risk in the UK of 2 with a large confidence interval, and it was predicted by the high testosterone and low SHBG. So the question we don't know is if we intervene in PCOS, suppress androgens, watch their metabolic complications, stop the progressive weight gain, can we impact on the fatty liver? We don't know that. However, the increase in PCOS was independent of BMI or abnormal glucose tolerance in this study. So in case 2, we're going to screen all women after and during their childbearing years for cardiovascular metabolic risk, and we're going to treat to the guidelines, their blood pressure, their lipids, and their A1C. We're going to optimize diet and lifestyle at all ages. We're going to ensure endometrial shedding with a birth control pill or at least cyclic progestin. We're going to evaluate for obstructive sleep apnea, and we're going to evaluate for fatty liver. Okay. Here's another case for you. 32-year-old woman who just got referred to us for PCOS, and we get a lot of this. She had a normal menarche, and she had no hirsutism or acne in adolescence. Her menses were really pretty regular during high school and college, and her BMI was 25. She conceived at ages 25, 27, and then 30. She's now 2 years later. With each pregnancy, unfortunately, like the rest of the world, she gained about 20 kilograms, but successfully only lost part of her weight. And now, in the last year, her BMI has increased to 33. And now she noticed hirsutism, some acne, and some irregular menses. Is this PCOS? Everybody says that all obese women who get hairy have PCOS, but is this really a story of PCOS? PCOS is a disorder that starts at puberty. And so what is this? And I think this is obesity-induced hyperandrogenism. This is a history of normal menarche and regular menses, but with progressive weight gain without any problems, they surpass a threshold weight. And then they have irregular menses, hirsutism, and acne. And the thought is that the peripheral fat tissue takes prohormones and converts them by aromatase into estrogen, but by 5-alpha reductase into testosterone. Then they have the hirsutism and acne. They often have cysts on their ovaries, but they're not the kind of subcapsular cysts. They're bigger and ovulatory cysts. Now, in these patients, it appears that successful weight loss below that threshold weight will reverse the phenotype. So we may treat them like PCOS. We may put them on a birth control pill. We may put them on an insulin sensitizer if their A1C is in the high normal range to prevent further weight gain. But should that group of women be treated primarily with weight loss drugs, as well as diet and lifestyle, etc.? More data is needed. Case 4. Final case. This is a 21-year-old university student who came to us with irregular menses and acne. Her menarche was not early, it was late, at age 15. She was an athlete in school. She missed some periods at age 17 to 18, and she had some life stressors. She has some hirsutism on her upper lip and below her umbilicus. Her BMI is 20. What labs would you consider in her? Does she have PCOS, a prolactin, an HCG, a testosterone, DHEAS, an ultrasound? So, let's raise our hands. Who would check a prolactin? I would, because 10% of amenorrheic women have hyperprolactinemia, and it would also be a sign that she might be pregnant. An HCG, all women with amenorrhea need a pregnancy test. Testosterone and DHEAS, you might check it, but her hair was just on the upper lip and below the umbilicus, about 20% in Caucasian women, and I think higher in South Asian women have that degree of hair. If you thought she had PCOS, you might get the other two. But it's important to know that not all women have PCOS. So not everything is PCOS. So don't forget about hypothalamic amenorrhea. It happens. And it happens a lot, of course, in Colorado, where everybody exercises, and if anything, they're too thin. But it's a GnRH pulse generator defect. It occurs, PCOS is 8 to 10%, hypothalamic amenorrhea is 3 to 5% of women. They're usually stressed. They're not always hirsute, but if they have familial hirsutism or ethnic hirsutism, it might be there. They're often thin, but they can be normal weight or even overweight if they have an eating disorder or they have a mood disorder. They're in college or in medical school. They can have larger, less numerous cysts on their ultrasound due to anovulation, but they have a low or normal LH that equals FSH, and they have a low estradiol. But the diagnosis is by exclusion and history. Their risk is estrogen deficiency, and we're going to treat them with an oral contraceptive to replace the estrogen and to regularize their menses. But not everybody has PCOS, and it's important to know that. So the take-home for PCOS and the metabolic and cardiovascular risks are that PCOS is 8 to 10% of women. It's associated with anovulation, with clinical or biochemical or both hyperandrogenism, with signs and symptoms of insulin resistance, which is not part of the criteria, but we often see it. Obesity is increasing in this population. Where I live in Colorado, we see mostly thin PCOS, but in the rest of the world, most people see obese PCOS. But not every obese woman has PCOS, and it's important to distinguish. Their risks are infertility, the obesity, the metabolic syndrome, the hypertension and the dyslipidemia, and early diabetes risk and gestational diabetes, and then following post-gestation, the diabetes risk, especially with family history. And some of the things that we need not to forget is their risk of endometrial cancer, perhaps increased risk of stroke if the hypertension and metabolic risks are not treated, maybe CAD, stay tuned. But this OSA, which is a cardiovascular risk, and the NAFLD, especially related to the BMI. So I think what we have to take away from this is women with PCOS need to have intervention early, in adolescence, and they need to be followed and aggressively followed across their lifespan so that they don't have to end up at age 32 in the infertility specialist's office. But we'll talk about that in another lecture. So the diagnosis requires early and continued intervention by all of us as healthcare providers. So again, to step back, hyperandrogenic anovulation, PCOS is the most common. Rarely we'll see an ovarian or adrenal tumor. Don't miss iatrogenic. I think there's this separate disorder of obesity-induced hyperandrogenic anovulation. We've excluded these other rarer causes, CAH, in the appropriate patient population. Familial hirsutism is not associated with irregular periods, but has the hirsutism part. Cushing's syndrome and prolactinoma can sometimes present with hirsutism. So with that, I'll stop, and if we have time, be glad to answer any questions.
Yeah,
Thank you.
There is some time for the questions. For the previous talk as well, menopausal hormone replacement, we can ask questions from that as well. So we got the same speaker.
I just wanted to ask, what is the natural history of PCOS after menopause?
I'm sorry, I can't.
Sorry, your voice.
What is the natural history of PCOS after menopause?
Yeah.
The metabolic risk, the cancer risk, and what happens to their hirsutism after menopause?
Yeah, so the question is, what is the natural history of PCOS after menopause? And we don't know. I mean, we have very little data. I think we know that historically that some women with PCOS, after they have their first child, some of the disorder improves. We know that women now are being followed with either the Rotterdam or the NIH criteria in the menopause. And again, the confidence intervals of metabolic and cardiovascular risk are blurring because of the thought that the rest of the population with aging gets the obesity, gets the hypertension, gets the metabolic risk, and you can't see the independent effects of the PCOS alone. So I think we don't have great studies of that because we didn't follow women. I mean, there's the epidemiologic studies in looking at the genetics of women who had, quote, hyperandrogenism, but again, that's somewhat muddied.
Any other questions from the floor? Anyone? Can I ask you, for the late onset CAH, who do you screen for it, number one? Number two, when do you stop screening for a late onset CAH?
Yeah, we're going to have a whole talk on CAH, and stay tuned for that. But in the context of PCOS, I think you have to screen based on ethnic predisposition, and there have been many studies showing the different risk ratios in different ethnics. If you do a follicular phase, 17-hydroxyprogesterone, and it's less than 200 nanograms, then you're free, that you don't need to do the more expensive stimulated ACTH stimulation test. In our part of the world, we're screening people who are Ashkenazi Jews, Eskimos, Mediterraneans, and Hispanics. Here, I think, depending on the risk ratios, I'll show some of the data of the incidence around the world of who to screen for.
Quickly, can you come to the mic, please, very quickly. Anyone who got 1 minute? Got any other questions? Just.
Nice. It was a nicely delivered talk.
Can you be a bit louder? Please.
Just two questions, small questions. You mentioned that the role of DHEA sulfate in the diagnosis of PCOS, how it helps, because we live in a resource-constrained society where investigations are merely a burden for a patient. Will it have any effect on the diagnosis of patient is PCOS or not? And secondly, taking the point from this 17-hydroxyprogesterone, we don't have any data available for this CAH in our setups. What we have read and what we do 17-hydroxyprogesterone for non-classical CAH in almost every patient we are suspecting PCOS. Is this right, or it should be on the basis of like Cushing and acromegaly, well, you don't see the phenotype or you don't suspect it, just skip that? Can we skip that in a patient? Because if you have not done that and you start patient on androgen and things like that, it can result in problems in a patient who has CAH.
That's a lot of questions. So I mean, some of the questions had to do with screening all patients for CAH, and that may be appropriate. Some of the other issues about use of DHEAS, androgens come either from the ovary or the adrenal. The ovary best marker is testosterone, although it also comes from fat. The best adrenal marker of androgens is DHEA sulfate. And so someone with PCOS don't have a very high testosterone, but have a high DHEA sulfate, and it becomes a good marker to see how you're responding with your androgens. So I think we'll stop there because we have another lectures coming. Thank you very much.
So let me, on behalf of the organizing committee, invite all of you to join us in showing our appreciation to the two speakers in the usual way.
Please give them a big hand.